Hello everyone, I am Dr. Shah and we will be starting today with PEDS. PEDS is very important as one scenario comes from PEDS in PLAB-2 exams, and maybe two scenarios also came from PEDS. Today we will be starting with PEDS, and first of all I will go through the approach of PEDS, and after that I will go through the scenarios one by one. So you already know the approach of medicine. The approach of PEDS is also similar to medicine, but there are certain differences that I will clear with the time. So moving on, the approach to pediatrics. Okay, so first of all, in pediatrics, you have to show empathy to the patient. Uh, as a mother or a father of a patient, like kids come, so you have to show empathy. You should understand their emotions, and you should revalidate. So you should clearly listen to the patient, and after that you should answer their questions. It is very important also that you understand their concerns and uh, answer to each and every of their concerns. So if a scenario come, the approach is usually grips. You should meet the patient, build the rapport, and start with the TUPA or STUPA KRS. And after that, you should ask the differential diagnosis. And two things are very important in PEDS. You have to ask in every scenario. These are PAM good and P bind. PAM good is usually 5 infections that you have to ask in each and every scenario. In PAM good, P is for pneumonia, A is for acute otitis media, M is for meningitis, G is for gastroenteritis, and U is for UTI or upper respiratory tract infections, and D is for dehydration. So moving on, in pneumonia, you have to ask two questions: that does the child has any fever? Does the child has any cough or chest pain? In acute otitis media, you should ask these questions: is the child crying while pulling the ears? Okay, and is there any discharge from the ear? And in meningitis, you have to ask if the child has high grade fever, any shying away from the light, have you observed any rash on the body? While in gastroenteritis, you have to ask these questions: is there any change in the bowel habits, any diarrhea, or any vomiting? In UTI, you should ask, does the child cry while passing the pee, or any strong smelling urine, or any pain in the tummy, or any fever? In upper respiratory tract infections, you should ask, does the child has any sneezing, runny nose, or flu-like symptoms? These are very important to ask these questions because a child cannot answer these questions. So you have to ask in every scenario so that if the reason of fever is any of the above infections. And there's one thing very important. You have to also ask for dehydration. In dehydration, you should ask the mother or father, is the child is passing any urine? Okay, and how many nappies have you changed in last 24 hours? If these nappies are less than 3, then it is a sign of dehydration. 3 or more are normal. Another question is, when the child is dehydrated, he is drowsy. So you should ask that, is the child drowsy? And there's another question you should ask, that does the child cry with wet tears, or when he cries, he does not have any tears? Okay. After that, you should ask some red flags. And after that, you should ask some of the histories, which is P-bind. P-bind is usually question about his baby's pregnancy or birth. In pregnancy, you should ask, how was it? Was there any complications during the pregnancy? Do you have regular follow-ups during your pregnancy? And in birth, we should ask, how was the delivery? Was it a normal delivery or was it a cesarean section? Does your child need any special attention after the delivery? Does he need any help with the ventilation, or was he admitted to the hospital after the birth? Immunization. In immunization, you should ask the father, yeah, or mother, is the child up to date with the jabs? In UK, the immunization protocol is under the jabs. So you should ask the mother, is the child up to date with the jabs? In nutrition, you should ask, is he eating and drinking well? And developmental milestones, are you happy with the child growth as compared to the other children of the same age? So you have to ask these questions in every scenario. One is P-bind, other is PAM good. PAM good is ruling out 5 infections, and after that you have to rule out dehydration, and after that you have to ask some questions about the pregnancy. So it is very important in PEDS. Rest of the scenarios are equal or same as that of medicine, but in PEDS you have to ask these questions. Other than that, you have to understand the emotions of the mother and also address every concern which mother or father asked. So PMMA polyfamily. So it is also very important to ask about the past medical history of the child, any current medications, any allergy to medication, any family history of any disease. After that, AIC, it means you should ask the mother, do you have any idea what is do you have any idea what is causing these symptoms? So do you have any concerns? Is there anything else that is bothering you? So these are questions which you have to ask in AIC. It is very important. So it is very important in interpersonal skills, because when you ask these questions, you are involving the patients. After that is OET. You all know that O stands for observation. You should check the vitals, in which you should check the pulse, temperature, examination, do the relevant examination, and T is for test. Advise some routine test and also advise some chest X-ray, etc. In management plan, disclosing and explain. In disclosing the information, you should summarize everything. If a child comes with a fever and air pain or air discharge, you should say that as your child came here with the fever and he was having some discharge from the air, based on these symptoms and after examination, I assume that your child is having a condition known as acute otitis media. So disclosing is like summarize first, then explain, and then tell the diagnosis. After telling the diagnosis, you can ask the parent that, do you have any idea about this condition? Or what do you know about this condition? She or he will say that I do not know about this disease. Then explain the disease in a layman language. Telling your decision is like the decision which you as a FY2 foundation year 2 doctors have to take, like initial management, initial what you will do, and targeted management. Targeted management is you can ask that I will inform my seniors and I will take a second opinion from my seniors, then I will tell you the management. After that is concerns. Concerns are very important. In pediatric scenarios, you should ask these concerns after completing everything, or you can ask them in the middle, and you should answer these concerns if a mother raised this concern anywhere. Okay, if the mother is concerned too much about her child, then you should do some E protocol, like, I can understand your emotions. Anyone in your position would have felt the same. So let me explain you in another way. Then tell him in layman language and try to involve yourself with the patients. After that, long-term management, in which you have to give leaflets and also ask some preventions and also tell him about the follow-ups. So this was a general approach to the pediatrics. And after that, we will be starting some scenarios. and we will do the scenarios one by one. So the first scenario is nightmare versus night terror. A nightmare is when a child wakes up in later part of the night and he is frightened, and when he wakes up at night, he can become comfortable and he remembers every event. In a nightmare, child will remember everything, and it occurs in the later part of the night. It is triggered by frightening experiences like watching scary movies. Child will remember everything and explain it to you when asked about. In night terrors, it is usually triggered by febrile illness, medication, and there is usually family history of night terrors or sleepwalking. So in nightmare, there is no particular reason for nightmares. The one reason is a child becomes frightened at night, and it may be due to scary movies which a child watches at night with the parents. And whereas in night terror, there is specific reason. And this is due to some febrile illness or medication, or there is some family history of night terror in the parents. So it occurs in the earlier night terrors occur in the earlier part of the night or and half or falling asleep. Child wakes up screaming. In nightmare, a child is comfortable. Child is not screaming, whereas in night terror, child wakes up screaming and child is confused, will not remember anything. It usually occurs between the age of 3 to 8 years. Both of these conditions are self-limiting, and there are some certain precautions which you have to take, and these conditions will resolve on its own. Management is only reassurance and explain these conditions to the parents so that they have good idea about these conditions. Management is reassure the parents they need to stay calm and wait until the child calms down. Try to talk to the child to see if anything is bothering them. Okay. So there will be a scenario in which a mother came and tells you that his kid usually wakes up at night and he screams and he is confused, and when we try to sleep him, he does not sleep. So this is scenario of night terror. Okay, so you will start with the grips. Confirm relationship with the child. Confirming the relationship with the child is very important. Okay, you should in GMC you should know the name of the child, and you should also take care about the gender of the child. Okay, also know the name of the child. So Tupa, how did it start? When did it start? Did it develop gradually or suddenly? Is there anything that making it worse? Is there anything that making it better, or it is getting worse with the time? So differential diagnosis are nightmare, night terror. Ask questions about these two conditions. That at what time of the night does it occur? Okay, what the child do when he wakes up? Is he comfortable? Does he go to sleep again? Okay, these is there any family history of this condition? Okay, any febrile illness, or is the child using any medication? So rule out these conditions by asking about these conditions, nightmares and night terrors. In nightmare, it occurs in later part of the night, and night terror occur earlier part of the night. In a child watches usually scary movies at night, and in night terror, there is some kind of conditions like the father has a history of night terror, or a child is having febrile illness, or a child is using any medication. In nightmare, you can calm your child, and in night terror, the child is screaming and he cannot be calmed at night. Okay. After that, the same P-bind, ask about pregnancy. How was it? Was there any complication during the pregnancy? Are you regular with your uh, follow-ups? Birth, how was the birth? Was it a normal delivery or section delivery? And does your child need any special attention after the delivery? Ask about immunization. Is your child up to date with the jabs? Ask about the nutrition. Does your child eats and drinks well? Ask about the development. Are you happy with the development of your child? Ask past medical history. Past medical history is very important as night terrors. In night terrors, there is family history of similar problem. Okay, and ask about the medication. If the child is using any medication, any uh, allergy to any medication, eyes effects of the symptom, how these symptoms are affecting the life, how these symptoms are affecting your life as well as the life of the children. Okay, and does he go to the school, does he go to school, does he go to nursery, does your child has any illness. Also ask questions about PAMDU, about pneumonia, acute otitis media, meningitis, upper respiratory tract infection, genitourinary infection. Okay, OET, observation, examination, and perform some routine investigations to rule out other conditions. There is no need to perform any examination. Then after that, explain is very important, and it comes under the management. So you will explain in a layman language as your child, as you came with your child and complained to us that your child usually gets up at night and in the earlier part of the night, and her father also has similar history. So from what you have told me, your child has night terrors. So then you will ask the parent, do you have any idea about it? They will say no. So you will say that usually it is self-limiting condition. Usually nothing needs to be done. Let me reassure you again that it will resolve on its own. Do not try to intervene or wake up the child. Okay. And in night terrors, when a child wakes up, do not try to intervene or wake up the child. Just stay calm until it passes. Most children grow out of it, and it has no longer long-term effects. So follow up is in 1 month just to check up on the child. Also distribute the leaflets about nightmares and night terrors. Okay. So the next scenario is constipation in a child. Okay, you all know about the constipation. Okay, and it is common in child. Okay, so you should know the reasons of constipation in a child. So when you have know the reason and differential diagnosis of constipation in mind, you can ask better questions from the parents. Okay, the question is F by 2 in GP surgery. 30 years Elena Jones has made an appointment to see you. She is concerned about a 2 years old child who has been constipated. She had visited GP surgery 2 weeks ago. Abdominal rectal neurological examination were done and she was advised on dietary intake. Rectal did not show any fecal infection. She was asked for follow-up in 2 weeks' time, talk to the patient and address her concern. So this is a follow-up scenario in which a patient has come 2 weeks ago and she was advised some dietary modification. Now the patient uh, came here, a child had patient info, child has been constipated for 2 months. Initially, child used to pass stools every day, but for the past 2 months, it's twice a week. For the last couple of weeks, she is passing stool once a week. 2 months ago, child has a fever and flu-like illness. Child diet is cereal for breakfast, toast for lunch, and pasta for dinner. Does not like water, fruits, or vegetable. Mother tells you that in her previous visit, doctor was in a hurry and did not assess her carefully. So this is your scenario. So in this, you will paraphrase the scenario. I understand that you brought grips in which you will ask the name of the mother and ask the name of the child and also ask the age of the child. Then paraphrase the scenario. I understand that you brought your child 2 weeks ago with the constipation and she was advised with a dietary modification. So how may I help you today? She will tell you that she is still constipated. So you will ask, I need to ask some questions so that I have a better understanding of the condition. So after that, again, top of her constipation, you will ask how many times a week does your child passes the stool? So this is the frequency. How many times a week does the child passes stool? How does the stool look like? Are these like rabbit dropping, a very hard stool like nuggets? Okay, this is due to dehydration. Has the child complained for pain and distress while passing the stool? Any blood in the stool or streak of blood? So these are specific questions related to constipation. You can ask also top for constipation. How did it develop? When did it develop? Is there anything that makes it better? Is there anything that makes it worse? After that, you will ask the frequency. How does the stool look like? And does the child complain for pain or distress while passing the stool? Any blood in the stool or streak of blood? After that, you will ask the precipitating factor. Precipitating factors in it, the diet is very important. So you have to ask like diet. What does he eat in the morning, at lunch, and in the dinner? Any recent illness? In recent illness, you can also ask about PAM good. Okay, does your child has any cough, any fever, any does your child cry while pulling the airs? Okay, does your child has uh, any strong smelling urine? Does your child cries while passing the urine? Okay, any inner fissure? You have already asked about streak of the blood. Is the child using any regular medication? Because medications can also cause constipation. Is the child toilet trained? Does the child have easy access to the toilet and stress at home or nursery? Because bullying is also one of the reason for constipation. And if the child is not toilet trained, and it can also cause constipation. Okay, these are, first of all, in constipation, you should start with the TOPA of constipation, then ask about frequency of the constipation, nature of the stools, and also if there is any discomfort or pain due to the stool. Then ask about precipitating factors. Precipitating factors can be medication, it can medication, recent illness, diet, toilet training. Okay, then ask about the red flags. In constipation, red flags are Hirschsprung disease, anal stenosis, and cystic fibrosis, on any neurological and spinal cord abnormalities. Ask if the child developed constipation in the first week of life or appearing from the birth. This is Hirschsprung disease. If the child does not develop constipation in the first week of life, it is due to Hirschsprung disease. Any delay in passing the meconium is common in cystic fibrosis. The stool which look like narrow ribbon are the characteristic of anal stenosis. Is there any weakness in lower limb? Any weakness in lower limb? Uh, it can also cause constipation. These uh, ask about any neurological and spinal cord abnormalities. Ask about PAM good and P bind. Okay. After that, PMA Holy Family. Ask about past medical history, medication, allergic to any medication, and past medical history. Okay. And after that, ask about OET, observation, examination, and also testing. In this, abdominal examination is important, but rectal examination is important, neurological examination of lower limb is important, because any spinal cord or neurological abnormalities can also lead to constipation. So in management, you should explain that we usually treat the constipation in a stepwise manner. First of all, we give dietary modification, and if the child does not respond to the dietary modification, then we will give any kind of medication. So from what you have told me and from my examination, your child has a condition known as idiopathic constipation, which was most likely triggered by infection child was suffering. And also it may be due to child's diet. Okay, because you have asked the mother about the child, and in diet he was not taking sufficient amount of water and fruits. So this idiopathic constipation was due to the febrile illness and also due to the child's diet. So decision is, as in first visit we have prescribed the child with dietary modification. So in the next visit we will give him some kind of laxatives. The laxative that is prescribed in pediatrics is microgol. So we will start with laxatives called microgol, is given for 7 to 14 days. Okay. Remembering the dosage is not very important in PLAB-2, but you should have the idea about it. If the child is less than 1 year, half sachet daily. If the child is 1 to 6 years, one sachet daily. If the child is 7 to 12 years old, two sachet daily. So follow up is same. Within 2 weeks, mother needs to give more fluid, vegetables, and fruits. This will help in opening up the bowel and it will also make the bowel softer. If no improvement in 2 weeks, then only we will make a referral to pediatrics. So the referral is in 2 weeks. In 2 weeks, you will give first dietary modification, and after 2 weeks, you will give medication. And after 2 weeks, if it does not resolve, then you will refer to pediatrics. So the mother will raise the concern the child wasn't assessed properly at that time, last time. So in this, you should, when a patient or a person asks you some question, you should first ask him, why do you think she wasn't assessed properly? You cannot ask that, oh, I can understand that he was not assessed properly last time. So you do not know about it. So the thing which you do not know in PLAB-2, you should not uh, tell that. Okay. The child was not assessed properly at last time. Why do you think she was not assessed properly? The mother will say that she was not given, child was not given any kind of medication. So then you will explain, I am sorry you felt that way, but when a child comes with constipation, we try to improve with the diet. And if that does not work, we use laxatives. So we have done with two scenarios now. And third scenario is pyloric stenosis. Okay, pyloric stenosis. So you all know about pyloric stenosis, in which distal end of the stomach is narrowed and usually the child has fountain-like vomiting. Okay, in this scenario, the child is admitted to the hospital and he came with dehydration and vomiting, and you are a doctor, you are going to talk to the mother of the child. So approach is same, grips, confirm relationship with the mother. I understand that he has been admitted to the hospital with vomiting and nurse has taken the vitals. How the child is doing now? Okay, she will tell the child is now improved now. So you will ask, can I ask a few questions to assess how the child is doing now? So the child came with the complaint of vomiting. So you will start with the tupa of vomiting. So how did it start? When did it start? Okay, and what the child was doing when the vomiting started, and is it getting worse with the time? Is there anything that makes it better? Is there anything that makes it worse? Okay, you can ask the frequency of vomiting. How many times has you vomited? What are the contents of vomiting? So these are the things which you have to ask about vomiting. So differential diagnosis, pyloric stenosis. In which pyloric stenosis, you have to ask the question that does the vomit looks like a fountain or does it drops on the clothes of the child? Okay, and also ask about, have you observed anything on the tummy when the child is taking any feed? Okay, after that you should ask about PAMGUD, pneumonia acute otitis media, meningitis, genitourinary tract infection, upper respiratory tract infection, and dehydration. It is very important to ask about the questions of dehydration in this scenario, because when a child comes with the vomiting or diarrhea, you will always have to ask about dehydration. Okay, is your child passing any urine? How many nappies do you usually change in 24 hours? Okay, does your child cry with wet tears? Ask about the red flag sign that about the dehydration. Ask about pregnancy, birth history, immunization, nutrition, and developmental history. After that, PMMA, Holy Family. Ask about past medical history of the patient, any medication, any allergy to the medication, any family history of similar condition. After that, OET, observation, examination, and test. On observation, you should check the vitals, check, check the pulse of the patient, check the hydration status of the patient, and which you will see in the eyes, in the mouth, and also uh, areas of the skull. Okay. On examination, you should perform abdominal examination. In pyloric stenosis, there is a test which is called feed test, in which the child is given some feed, and after that, examination of the child tummy is done while the mother is feeding the child. And uh, when you examine the abdomen, you feel like an olive-shaped mass in the abdomen. This is called feed test. This test is very important in pyloric stenosis. Management, so you should summarize the case. After that, you should tell the patient from what you have told me and from my examination finding, it is most likely pyloric stenosis. Do you know anything about it? Okay, we are going to send some blood test. Okay, do you know anything about it? She will say that I do not know about this condition. Then you will explain this condition, that pyloric stenosis is a condition in which distal part of the stomach is narrow, due to which the child develops symptoms like fountain-like vomiting. So to confirm this condition, we are going to perform some tests. The blood test, which is very important in pyloric stenosis, is arterial blood gases. If it is confirmed, okay, and other test that is diagnostic for pyloric stenosis is abdominal ultrasound. If it is confirmed after the scan of the tummy, we will do surgery. Child will be explain the surgery to the patient. Child will be put to sleep for surgery. I will also ask second opinion from my senior. If there is any change in management, I will let you know. Yes, so the mother will ask, can I take the child home? So you will tell the mother, yes, you need to, no, you cannot take the child to home, because you need to stay, because the child is dehydrated and needs fluid through the vein. Okay, we have done 3 scenarios. And there is break for 10 minutes, and after 10 minutes, we will be starting with breast milk jaundice. So the fourth scenario is breast milk jaundice. In breast milk jaundice, the baby usually comes within the first few weeks after birth and is jaundiced. So FY2 in pediatric ward, 3 weeks old baby has been referred by community midwife. Other info has been referred with the jaundice. Talk to the mother and address her concern. Discuss management with the mother. Patient info is this is 3 weeks old baby found to have jaundice 2 weeks ago. Otherwise, well, no fever, no problem with the pregnancy. She was delivered at 38 weeks. Mother is happy. She is gaining weight. This is the first visit to the hospital. Question: what is wrong with them with my child? Why did it happen? What should I do? So this is the breast milk jaundice, and and patient. This is the breast milk jaundice, and this patient is referred by the community midwife. So you will paraphrase the scenario. I understand that you have been referred by community midwife, and I understand that Liz has jaundice. Can I ask a few questions so that I can have a better understanding of the child condition? So the breast milk jaundice is common, but you have to rule out the dangerous conditions. Okay. For jaundice, how did it happen? Did it develop gradually or suddenly? When did it happen? Is it getting worse with the time? Is there anything that makes it better? Is there anything that makes it worse? So the differential diagnosis of jaundice in newborn babies is biliary atresia. This is a quite dangerous condition, so you have to ask about questions about this condition. In biliary atresia, you should ask about, does the baby passes pale stools, and is the baby passing any dark urine? So hemolysis is also one of the causes of jaundice. So you will ask about, is there any family history of bleeding problem, liver problem, any bruises anywhere in the body? Okay, this is hemolysis. And in breast milk jaundice, you will ask this question: are you breastfeeding the child only? Are you breastfeeding the child only? Okay, and any bruises, any seizures, because they indicate any liver problem. Okay, after that you will ask about PAM good. In pneumonia, you will ask, does the child has any fever or cough? In acute otitis media, does the child cry while pulling the air? Any discharge from the air? In meningitis, and does your child shy away from the lights? Okay, any rash? Have you observed any rash on the body? Any genitourinary symptom? Does the child cry while passing the pee? Any strong smelling urine? Any change in the bowel habits? Any vomiting or diarrhea? Okay, red flag signs that you have asked. These are the signs of biliary atresia. You will ask, is the child passing any pale stools or dark urine? Then ask about P-bind birth history. How was the pregnancy? Uh, were you regular in the follow-ups? How was the birth? Was there any complication during the delivery? Does your child need any type of attention or care during the birth? Is your child up to date with the immunization? Okay. Nutrition. In nutrition, you will ask that, is the child eating and drinking well? And after that, dehydration question. There are three questions for dehydration. So you will ask that, is your child passing urine? How many nappies does she wet in 24 hours? Okay. And is the child crying with wet tears? Past medical history: is there any family history of liver problem? Any family history of biliary atresia? Okay. And is the child using any medication? Okay. Does the child have previous history of hospitalization, OET, observation? You will check the vitals of the child. You will check the pulse and head to toe examination to observe for jaundice, and perform some of the tests. Okay. In management, you will explain that, as your child was brought here and it was referred by community midwife, it seems that your child has developed breast milk jaundice. Breast milk jaundice is common in newborn because liver is not mature and not ready or effective enough to deal with the pigment called bilirubin. Jaundice usually develop in first 2 weeks of life, but in breastfeeding child, it may last longer. So there is an enzyme in liver that usually degrade bilirubin. That enzyme is not mature to degrade the pigment bilirubin. So it usually accumulate on the skin and usually cause jaundice. In management, we will perform some of the routine investigations to rule out any dangerous condition. So we will perform urine, complete heel prick test. Heel prick test is performed by pricking on the heel, and in heel prick test, we will check the amount of bilirubin And we will also measure the amount of bilirubin using a device called bilirubinometer. It is very important test to check the amount of bilirubin on the body. So it is usually a small device uh, in which a beam, which uses beam of light on the baby's skin and measures the amount of bilirubin. Okay. So there is some level of bilirubin. If if the level of bilirubin is above that normal level, then the UV light phototherapy is suggested. But if that level is less than the dangerous level, then there's no need to do anything. So in most of the PED scenario, the one thing you have to do is reassure the mother, talk to the mother, listen to the mother, and understand the emotion of the mother. Okay, and repeat same things again and again, and explain some of the conditions in layman language and in layman language, and also in easy way. So you will ask that this is a self-limiting condition. Nothing needs to be done at the moment, and I have already told you jaundice is common in newborn babies. It will resolve on its own. You can continue breastfeeding. No treatment is required. Safety netting is safety netting of biliary atresia. If the child develops biliary atresia, if the child passes pale stool, dark urine, or if the child develops high-grade fever, please come back and we will assess your child again. Otherwise, follow up in 1 week time just to check on the child. Leaflets about the breast milk jaundice. So the mother will ask, if it is a breast milk jaundice, do I need to stop breastfeeding? No, just continue breastfeeding. It will resolve on its own. This scenario of breastfeeding jaundice is very common, and it mostly comes in GMC. So the next scenario is about bronchiolitis. Bronchiolitis is also common in peds, and if your exam is in winters, it may probably come in your exams. Okay, bronchiolitis, it is usually a viral infection. It usually comes with sneezing, coughing, shortness of breath, and noisy breathing. Okay, and it is a viral infection. It also resolves on its own. But if the child is having a severe symptom, then we need to admit the child. Okay, moving on to the scenario, bronchiolitis. So the child will come with a respiratory distress, or with the flu-like illness, or with the cough. So grips, confirm relationship, TOPA, differential diagnosis. In differential diagnosis, you will have to ask about asthma. Is there family history of asthma or eczema? Anyone smokes at home? Is there any dust at home? I am good. You have to rule out these 5 infections. Any fever, any cough, any does the child cry while pulling the airs, any discharge from the air, meningitis, any rash on the body, any shying away from light, and genitourinary. Okay. Genitourinary, you have to ask, does the child cry while passing the pee? Okay. And does the child cry while passing the pee? Any strong smelling urine? And also gastric signs, any change in bowel habits, any diarrhea or any vomiting. Ask about dehydration, because dehydration is very important in the case of any respiratory scenarios like asthma or bronchiolitis. Okay, ask about, does your child is your child passing normal urine? How many nappies do you change per 24 hours? And does the child cry with the wet tears? Ask about red flag sign. The red flag signs are any kind of cyanosis, any kind of bluish lips or blueness of the body, and also ask about apnea, any cessation of breathing. Okay, ask about P-bind. How was the pregnancy? Were you regular in your follow-ups? Birth. How was the birth? Was it a normal delivery or a C-section? Immunization. Is your child up to date with the jabs? Asking about immunization is also important in it. Ask about nutrition. Is your child eating and drinking well? Okay, and eating and drinking well. Ask about development. Are you happy with the development of your child? PMMA, Holy Family, in which we will ask about past medical history, A, in which medication and allergy and family history of any disease. Okay, ask about the asthma, any family history of asthma and eczema, anyone smokes at home, OET, observation, examination, and test. In observation, you should check the saturation, check the pulse, and examination, you should perform the chest examination and also perform the relevant test. If so, in management, if the oxygen saturation is less than 94, then we give oxygen. If the child is dehydrated and not feeding properly, then we use NG feeding. Okay, and if the child has severe crackles and wheeze is present, then we need to admit the patient. So these three are symptoms which are very severe symptoms, and we do not send the child home on the if the child is having any of these symptoms. So we need to admit the child if the saturation is less than 94, if the child is dehydrated, and on auscultation the severe crackles are present. Okay. Bronchiolitis is usually common, and it is common in babies less than 2 years of age. The most common cause of bronchiolitis is respiratory syncytial RSV, respiratory syncytial virus. Okay, and the main sign and symptoms of bronchiolitis are cough, runny nose, noisy breathing, and difficulty feeding, and having fever, and the child may be irritable. And there is increased risk of bronchiolitis in at home in which someone smokes. Okay, management, if the child is having mild symptom, then we need to reassure the parents. It usually gets better on its own in 2 to 3 weeks without treatment. Advise parents, if the child has fever, give paracetamol or ibuprofen to relieve the temperature. Isolate the baby, isolate the child, because it is a contagious and it can pass on to the other child. Okay, fluids to prevent dehydration. Keep the child in upright position because it makes the breathing easier. Child away from smoke inhalation. And this is very important because the lungs are not well developed in children. So it is very important to keep the children away from smoke inhalation. So there is criteria for admission. I have already told you, if the child saturation is less than 94, okay, and if you hear severe crackles, and if the child is not feeding or drinking well, then we need to admit the patient. If the oxygen saturation is low, if the child is dehydrated, severe wheeze or severe symptoms are present, and okay, we need to admit the child, and NG tube if the child is severely unwell. Investigation if severe symptom. So the gold standard or investigations of choice in bronchiolitis are chest X-ray and nasal swabs. After that, distribute the leaflet and give the leaflets about bronchiolitis. So in pediatrics, it is also very important to ask the mother to come for follow-up if the child condition is getting worse with the time, or if we need to check the child again. And it is also very important to give leaflets to the mother, because in pediatrics, it really give good impact if you give leaflets to the mother. Okay, the next scenario is acute otitis media. In this scenario also come with the examination. So in acute otitis media, uh, uh, if the examination is given, that's good. If the examination is not given, then you need to have a look at the dummy, at the mannequin. There will be mannequin of air, and you have to perform examination at the mannequin. So acute otitis media is one of the most important scenario in pediatrics, and as well as in examination. So you should also know about the slides of normal air and also differences between acute otitis media air bags. So these are the these slides are important. So these slide, you should also know the difference about normal air and the air of acute otitis media and viral acute otitis media, bacterial acute otitis media. You should always know the difference between these things. Okay, FY2 in pediatric department, patient 10-month-old child Angela has been brought to the hospital by her father. Other info, the child has been examined. So in this scenario, the child has been examined, but in certain scenario, the child, they do not give the examination. So you have to look, when you go into the room, then you have to look around and see if there is mannequin, then you have to perform the examination as well. Okay, the child has been examined. The temperature is 39 degree, pulse is 146 beats per minute. Blood pressure is 90/77. Air examination, tympanic membrane is pink in the left ear. Please talk to her further and discuss management with him. Patient opening sentence. Father, how is my child? Angela has been unwell for the past 2 days with a fever of 39 degrees. She has been crying and pulling her right ear. Up to date with all immunization. Child is normally well and not on medication. Mother of the child is at work. Question, what is wrong with my child? Will you admit her? What are you going to do for her? So in bronchiolitis, in acute otitis media, and in certain scenarios, it is very important that you should ask about the feeding and drinking habits. So if the child is not being able to drink or feed well, it is very important that you have to admit the child. Okay. So approach is grips, greet the patient, build rapport, and after that confirm relationship with the child, TOPA, TOPA of ear pain. Okay. After that, differential diagnosis is PAMGO. Ask about in every infection, it is very important to ask about PAMGO. In PAMGO, pneumonia, ask about does the child has high grade fever, does the child has cough, does the child cry while pulling the ears, any discharge from the ear, does the child, is your child shy, is there any shying away from from the light, okay, have you noticed any rash on the body, any neck stiffness, okay, gastric and change in bowel habits, okay, and any vomiting, any passing of loose stools and urinary, in which you will does the child cries while passing the pee, any strong smelling urine, okay, and respiratory tract infection, any cough, wheezing, runny nose, and dehydration is very important, also very important in acute otitis media, in which you have to ask about does the child is the child passing any urine? How many nappies do you change in past 24 hours? Is the child crying with the wet tears? Okay, red flag signs. Red flag sign in acute otitis media are that of meningitis. P bind, ask about pregnancy, birth, immunization, nutrition, and development. PMA, Holy Family, past medical history, medication, allergy, and uh, family history. OET, observation, examination and testing. Examination is very important. You have to look into the air with otoscope, okay, and in observation, check the temperature, check the pulse. Management, okay, then explain that examination findings are already given to you. Routine in examination urine dipstick is very important. Explain. Temperature is high. Examination of the air showed that the eardrum is red on the left side. Explain the diagnosis from what you have told me and from my examination finding. She has red eardrum on the affected side. Angela has a condition called as acute otitis media, which means ear infection. Management depends on the duration. If the ear pain is 3 or more days or symptoms for 4 or more days, otorrhea or bilateral symptoms are present and age is less than 2 years, this is the indication for antibiotics. Okay. In another scenario, there is a 2 years old child and tympanic membrane is pink and no otorrhea, so we do not give antibiotics because it is viral otitis media. So antibiotic of choice is amoxicillin. You should ask about allergies and PMA Holy Family. If there's any allergy to amoxicillin, then use clarithromycin, paracetamol or ibuprofen for temperature. The parents need to make sure the child takes test and give plenty of fluids to the child. Follow-up is usually in 3 to 5 days to GP. Safety netting is for the symptoms of meningitis, high-grade fever, develops rash, shying away from the light. Okay, the next scenario is febrile convulsions. So febrile convulsions are also common in pediatrics age. Okay, and febrile convulsion can be due to any kind of infection which causes usually high-grade fever. It can be acute otitis media, it can be pneumonia. and which causes high grade fever, and it can cause convulsions in a child. Okay, so the child will come and he was having fever and also developed convulsions. So Grips confirmed relationship with the mother or father. I understand Jenny had a fit at home and she is also running a fever. Can I ask you a few questions to understand the situation better? Okay, and ask symptoms before, during, and after the convulsions. Before, you will ask what Jenny was doing when she had a fit. Okay, where she was, has anyone noticed the fit? And during febrile convulsions, you will ask the questions like, does she lose her consciousness? Okay, ask about the conditions of epilepsy, any uprolling of eyes, any frothing from the mouth, any incontinence of urine or feces. Okay, and after conversion, how many times after conversion does she gain consciousness? Was she having any kind of headache? Okay, and then after that, ask about family history of epilepsy and febrile convulsion. Ask about PAM-good, every symptoms of PAM-good. Does the child has any fever, any cough, any chest pain, acute otitis media? Does the child cry while pulling the ears? Any discharge from the ear? Ask about meningitis, any rash on the body, any neck stiffness, any shying away from the light. Ask about gastric symptoms like any change in bowel habits, any vomiting, any loose motion. Ask about urinary symptoms, any passing of. Does the child cry while passing the pee? Okay, and does the child has any strong smelling urine? Okay, upper respiratory tract infection, any flu-like symptoms, and cough, sneeze. Ask about dehydration as well. Red flag sign P bind, ask about pregnancy, birth, immunization, nutrition, and development. PMA Holy Family, ask about family history of epilepsy, family history of febrile convulsion. OET observation. In observation, check the pulse, check the temperature, head to toe examination, examination test, routine investigation, urine complete. Okay, explain. I understand after she was brought with the high grade fever and air exam was done, she has read eardrum and she has a fever. So it seems that she has a condition called as febrile convulsions. Children develop a fit when they have high grade fever. In her case, it has happened due to otitis media, which has caused a high fever. So in age 6 months to 3 years, febrile seizures or common seizures are usually harmless. Almost all the children make complete recovery afterwards. Okay, so there is chance that she may have this again when she has a high temperature in future. What measures need to be taken? So these are the precautionary measures then that you have to tell the parents that about their children. So if the seizure is greater than 5 minutes, you should call an ambulance. If there is any sign of meningitis like high grade fever, non-blanching rash, you should uh, come back to the hospital. Otherwise, no need to take to the GP, but no need. Uh, Otherwise, if the child does not have these symptoms, then take the child to the GP. No need to call an ambulance. So management rule out UTI with urine dipstick, paracetamol, ibuprofen, amoxicillin, and antibiotic of choice. If she is allergic to amoxicillin, give clarithromycin. So the mother will ask that doctor, can it be meningitis? So you will say that it is not meningitis because meningitis you will present with high grade temperature, shying away from the light, neck pain, and body rash. It is highly unlikely that in Jenny's case, safety netting is about meningitis. Okay, the next scenario is head injury in a child. Head injury in a child case is also important. So the child will come and there will be some kind of injury to the head. There are two scenarios in which you should rule out non-accidental injury. The one is head injury in a child, the other is head injury in elderly. Okay, if a child falls or if an elderly falls, so then you have to rule out non-accidental injury if there is any kind of abuse going on at home. Okay, Graves confirmed relationship, incident history before, during, after. Before, how did it happen? When did it happen? What the child was doing? Did anyone witness the incident? During the incident, does the child loses its consciousness? Okay, any uprolling of eye, any uprolling of eye, frothing from the mouth, and incontinence of urine or feces. And uh, after how many times after the head injury uh, does does he lose his consciousness after the injury? After how many times does he gain the consciousness? Was he confused after the head injury? Okay, then rule out non-accidental injury. Is this the first time or has it happened before? Who does she live with? Is your partner the biological father of Jenny? Does Jenny have any bruises anywhere on her body? Who usually takes care of Jenny when you're not home? Drug abusing parents. Okay, and any parents use any kind of drugs like alcohol or any cocaine or heroin, etc. Okay, rule out differential diagnosis. Pam Good asked about the symptoms of FIO infection. Red flags of serious head injury. Was Jenny drowsy? Okay, any discharge from her ear, nose, or throat? Any loss of consciousness after the injury? How many times did she vomit? If it is greater than 3, then it is a red flag. Any seizure-like activity. Ask about P-bind. Ask about family history, medication, allergy, OET, observation, examination, and relevant test. Examination, ear examination, nose examination, and throat examination. Explain. So this child came with a mild head injury and she was not having any kind of red flags. So the management is from what you have told me and examination finding, Jenny most likely has mild head injury. Right now, nothing needs to be done, but we will observe her for 4 hours in the department. We will give her something to eat and drink if she can drink, and if she can eat, everything is okay. We will discharge her home. But while she is at home, if she loses consciousness and if she vomits repeatedly and if she is drowsy and fits, you need to seek immediate medical help. Okay, it is very important to ask to tell these symptoms. So this is safety netting. Safety netting is also very important in pediatrics because the in peds population usually is a younger population, and reassurance and addressing the concerns of the parents is very important. So she will ask, does she need any kind of CT scan? So you will ask, the CT scan is not required for mild head injury. It will expose her to unnecessary radiation, more risk than benefits. Okay, the next scenario is of intussusception. The intussusception is a thing that in which one segment of intestine is telescoped into the other part of the intestine, and it usually causes obstruction of the bowel, and it usually comes with the obstruction of the bowel symptom like uh, the child has a very inconsolable cry, and the child usually pulls her legs toward her chest and passes like jelly like stool. So starting with intussusception, F5 in pediatric department and to 18-month child has been referred to the hospital by the GP with his mom, Emma White. Other info, child is with the nurse next room, take a focused history and discuss management. And this scenario can also come with this approach that the mother usually, when the mother came, she has some kind of GP letter, and the GP has examined the child and you are in pediatric department, and then you will further explain about the child. Patient info, your child has been crying for the last 10 hours. He would cry for 5 minutes, then stop for 1 minute, then continue repeating, crying while pulling the legs toward the tummy, diarrhea 2 to 3 times with the blood in it. Up to date with the vaccine, no significant past medical history. Stool is jelly-like, child has been lethargic, unable to eat and drink properly. Question, what is wrong with my child? Will you admit him? What is air anymore? So approach is grips, confirm relationship. So I have already told you that it can also be like uh, uh, the GP has already examined the child and has given a GP letter. So dear doctor, thank you for seeing this 18-month-old child who came with excessive crying. On examination, I found a pulse to be 140 per minute. Child was pale and lethargic. There is a mass in the right upper quadrant. Thank you for your opinion. So you will paraphrase, I understand you have been referred to the hospital by the GP. Do you have a GP letter with you? She will give us the GP letter. So you will take that GP letter and have a look at the GP letter for 1 to 2 minutes and understand the scenario. Paraphrase, I understand that you have been referred. Okay, can I ask you a few questions? What made you to go and see the GP in the first place? Oh, okay, she will say that the child was crying excessively, then TOPA for excessive crying, or did it develop gradually or suddenly? When did it develop? Okay, is it getting worse with the time? Is there anything that makes it better? Is there anything that makes it worse? So usually child cries in paroxysm every 10 to 20 minutes of crying, then stops and restarts. Red jelly like stools, differential diagnosis. Pam Good asked about every symptom like pneumonia, acute rhinitis, medium meningitis, gastric symptom, UTI, upper respiratory tract infection, and dehydration. Red flag signs are that of dehydration. Ask about P bind, okay, birth history, immunization, nutrition and development, past medical history, family history, and medication and allergy. OT examination, GP has already done it. Palpable right upper quadrant mass. Explain. As I can see from my GP letter, your GP has examined the child as he found the heart rate was increased and there is mass present in the child's tummy. From what you have told me and examination finding, most likely the child has got a condition called as intussusception. In this condition, one part of the bowel slides into another part of, like telescope, and this causes bowel to become blocked or obstructed. Management for no, in management we usually do air enema in which air is pushed through the back passage and the telescope segment comes back to its normal position. So management for now, we will admit the child and give IV fluids and NG tube. NG tube is for decompression of stomach. Then we will send for investigation, routine investigation, including full blood count, urine electrolyte, glucose level, abdominal X-ray, and abdominal ultrasound. Investigation of choice is ultrasound, abdominal ultrasound, no-nut sign or target sign is seen. Once the diagnosis is confirmed, treatment will involve a procedure called air enema. So whenever you are telling a new thing to a patient, you need to explain that thing to the patient, like air enema, endoscopy, colonoscopy. These are the things you have to explain in a layman term. So these things have their marks. In this procedure, a small tube is passed through the back passage of your child, then air is pushed into the bowel using this tube. Pressure of this air helps to reverse the telescoping of the bowel. If it is successful in 8 to 9 out of 10 patients, if the enema does not work, then we might need to do an operation. I will take second opinion from my senior. Any change in management plan, I will inform you. Offer leaflets. Okay. And there is break for 10 minutes, then we will start with the 10 scenario. So the next scenario is recurrent tonsillitis in a child. Okay, this is a child which usually have episodes of tonsillitis. Mother brought the child to the GP, and let's do the scenario. FY2 in GP surgery. Patient is Priyanka Jones, who has come to see you to talk about her son Robert, who is 9 years old. Other info: she was referred to ENT by another GP in the surgery for tonsillectomy for her son 2 weeks ago. Specialist has seen the son and refused to perform the procedure. Sent back to the GP. Past medical history: 3 episode of tonsillitis in last 6 months. Treatment treated with antibiotics. Clinical presentation: pus, discharge, fever, and sore throat. Patient info: my referral was rejected. Is NHS trying to save money? My son had 3 episodes of tonsillitis and in the last 6 months, 5 episodes. In the last 12 months, took only took him to the GP for the 3 episodes. Did not mention the other 2 episodes to the GP. When he has tonsillitis, he has fever, and I take him from the school. P-bind history is normal. Talk to the mother, take focus history, address concerns. Question: what are you going to do now? Why was the procedure not done? Is it because I do not have any money? Okay, so this is a scenario of tonsillitis in which the patient was referred to the ENT, and ENT, after taking further history and performing the examination, referred the child back to the GP. So you are a GP and you are now going to take the history and also perform the examination. Okay. Grips, confirm relationship, paraphrase: I understand you were referred to the ENT specialist for tonsillectomy for your son Robert 2 weeks ago. Can I ask you a few questions about that so that we can better understand the condition of your child? So ask about the referral. So when was the referral was done? What did the specialist say? How many episodes of tonsillitis has Robert had in the last 1 year? What type of symptom does he get? Effect of symptoms on the life. Okay, and also ask about Pam Good. Does your child has any fever, any cough, any pain in the air, any discharge from the air? Does he cry while pulling the air? Ask about the symptoms of meningitis, any rash on the body, any neck stiffness or neck pain, any shying away from the light. Ask about gastric symptoms. So any diarrhea, vomiting, any change in bowel habits. Ask about urinary symptoms. Does the child cry while passing the pee? Any strong smelling urine? Okay, and upper respiratory tract infection signs like any fever, cough, sneezing. Also ask about dehydration. Ask about dehydration in tonsillitis too. That does your child is your child passing normal urine? How many nappies does your child wet in 24 hours? Does he cry with the wet tears? Red flag signs: P-bind, pregnancy, birth, immunization, nutrition and development. PMA, Holy Family. Ask about past medical history, medication, allergy and family history. OET, observation, examination and test. Management, explain the positive find. Explain, summarize the positive finding. Mother is angry. As the mother is angry, apply the Eve protocol. The Eve protocol is very important in PEDS because you have to validate the emotions of the mother and answer to it in a very sympathetic and empathetic way. I can understand that you are disappointed with what has happened. I am sure everyone in your position would feel the same way. I am sorry about that has happened. I am sorry that you were referred too early for assessment for tonsillectomy. So it is very important that you listen to the mother and answer to the mother in your own way. Okay, and lower your tone and see in the eyes of the mother and ask him that I am very sorry to hear about that, and this should not have happened, and I'm really sorry that you were referred too early for assessment of tonsillectomy. But we just wanted to make sure that we are not missing any indication for tonsillectomy. Okay, let me explain the criteria for tonsillectomy. It is done if the patient has 7 episodes per year in 1 year, if 5 episodes per year in 2 years, and 3 episodes per year in 3 years. If this criteria is met, then consultant need to examine again and And if the consultant thinks that tonsillectomy is needed, then tonsillectomy is done. Okay, why not perform it anyway? Why was it not done? As your child had only 5 episodes, he does not meet the criteria for surgery, and tonsillectomy is only done when specialists make sure it is really needed. Okay, there are 2 points. Okay, if the criteria is met and if the specialist makes sure it is really needed, because tonsils are very important part of our body, and it you will perform the defense mechanism and fights against infection in our body. So if we remove them, it will reduce the ability to fight the infection. So in tonsillitis, so you have to explain the mother that why it was not done. Okay, and because it was not needed, and uh, as criteria is also not met, and specialist has not made sure. So in management, you have to reassure the mother. Whenever Robert has tonsillitis, you can give him paracetamol or ibuprofen for fever or pain. Salt water gurgling can help. Avoid hot drinks as it can worsen the pain. You need to give him plenty of fluids so he is not dehydrated. Robert can go to school after the fever has dissolved. He does not need to take off the school, as you need to make sure to bring to the GP after every episode of tonsillitis, as all the episodes need to be documented. So there are 2 things. Tonsillitis is affecting the school activity of the child. In UK, schooling is very important. Going to school is very important. So in these type of scenarios, you can ask how these symptoms are affecting your child. Then she will tell you that Robert cannot go to school because of the symptom. So you can say that try to give paracetamol and ibuprofen and also hot water gargling. As the symptoms are resolved, the robot can go back to the school. Okay, offer leaflets. Giving leaflets in pediatric scenarios are very important. Okay, chlamydia eye infection in a child. Chlamydia eye infection. This is a scenario. This is not complete scenario. Okay, this is scenario in which the child develop redness of the eyes and also some discharge from the eyes. So the doctor diagnosed the child with chlamydia and gave him chloramphenicol, and the child recovers with the infection. Okay, and the mother was tested, and mother was found to have chlamydia infection, that is sexually transmitted infection. Okay, so this is some of the scenario in which the mother is angry that she has only one partner, that is her husband. So you will ask, I do not know about this matter. This is the thing you need to talk to your partner. So the mom will say, I do not want to talk to him as I'm really angry. So you can say that we can use a partner notification program and call him and get him tested. Won't tell him that where we got details from. Okay, so you will tell the husband you will tell her husband about and call him, and so that he can get tested. So the treatment of chlamydia infection, the chlamydia eye infection in child is due to chlamydia infection of the mother, as she gave birth to the child. As the child got this infection, the treatment is doxycycline for 7 days, follow up is 1 week to see if the infection is eradicated or not. So the next scenario is fever in infant. It is telephonic consultation. Okay, so okay, there's some change in this approach in telephonic conversation. When a telephonic conversation came, as this is socially distanced lab, so you will find many scenarios will be of telephone or video call. So first of all, in telephonic scenario, you should ask the name of the other person. Okay? Check the identity of other person, then you introduce yourself. You can ask with whom I am talking to. Then she will tell that I am this. So then introduce yourself that I am Dr. Shiraz and I am one of the doctors in the department. Can I check few details before we talk? And she will say yes. Can you confirm your name? Can you confirm your date of birth? Can you confirm your address? Okay, and if the line cut is this the same number, I will call you. Okay, this is the approach of telephonic conversation. First of all, ask the name with whom you are calling, then introduce yourself, then ask about their details. Okay, moving on to the scenario, F52 and GP surgery. Helen Brown, 30 years, is registered on the triage list of telephone consultation in your GP surgery. She wants to speak to you about her 10-month-old son, David Brown. Okay, remembering the name in pediatrics is important. It gives good impression. Talk to the mother and address her concern. Telephone is connected. Please do not touch anything. Other info: child has no known illness and no known allergies. Talk to the mother, address her concern. Special note: patient is on the phone. The phone call is connected. Okay, this is a fever in infant. So in fever, you have to rule out those 5 infections, that of Pam good. So the opening sentence of the mother will be, doctor, can you come home and see my child? Child is running high grade temperature. Check the temperature. It is 39 to 40 degrees centigrade. Giving ibuprofen, temperature is not coming down. Child has had cough, runny nose for the past 24 hours. He is not feeding well for the past 24 hours. Hasn't changed any nappy because has not passed urine. So these are all red flags: not passing the urine, not feeding well, and high grade fever. These are all the red flags, and the child needs to get admitted to the hospital. Prior to that, child was fit and well, up to date with the vaccination questions. Can I bring him to the GP surgery? Can you prescribe antibiotics for him? Okay, so this is a telephone scenario. Greet, hello. They will say hello. Check the identity. May I know who is calling? Then introduce yourself. Then after that, check the details. Can you please tell me the full name of your child, date of birth and address? Ask what they want. How can I help you? Can I call you back on the same number if the line gets cut? Explain. So how can I help you? Then the patient will say that my child is running high grade temperature, that is 39 to 40, not feeding well and not passing the urine. So after that, she has told you, this is very important, that you should show the e-protocol here. I am really sorry to hear about that. Okay, I am really sorry to hear about that, and this must be distressing for you. And I need to ask you some questions so that I can be in a better position to help you. Okay, from what you have told me, David temperature is high and he is dehydrated, so he needs to be admitted to the hospital. Pam would ask about fever and cough. Acute otitis media. Does the child cries while pulling the ears? Any discharge from the ear? Meningitis. Does the child has developed any rash on the body? Any shying away from the light? Okay, any neck stiffness or neck rigidity, gastric symptom? Any ask about any change in bowel habits, any vomiting or any diarrhea? Ask about urinary symptoms. Does the child cry while passing the pee? Okay, any strong smelling urine? And ask about upper respiratory tract infections and any cough, fever, sneezing, and flu-like illness. Ask about dehydration. Okay, in how many nappies have you changed in past 24 hours? And does the child cry with wet tears? Ask about red flag signs or that of dehydration, not feeding well and high grade temperature. Ask about pre-bind pregnancy, birth, immunization, nutrition and development. PMA, Holy Family. Ask about past medical history, medication, allergies, family history. OET, observation, examination and test management. Diagnosis. So the diagnosis, you will say that your child, from what you have told me, that your child is having high grade temperature as he is not feeding well and also not drinking well. He is in a very critical position. So it is very important that you should take the child to the hospital immediately. So at the hospital, I am not sure that what is causing this high grade temperature. So at the hospital, he will be assessed by the specialist. They will ask you questions, examine the David and run some tests. As he is dehydrated, he may also be given some fluid through his veins. It is important for you to take David immediately to the hospital. Do you have, so you will ask that it is very important for you to take David immediately to the hospital. After that, you can ask, can you do it? Okay. Do you have any means of transport to the hospital? She will say yes or no. The mom say, no, doctor, I'm alone. I do not have any means of transport to the hospital. Can you call the ambulance? So, and to the convenience of the mother, you will say, yes, I can offer to call an ambulance. Would you like me to do that? So, ask her to call the ambulance by herself, and if she does not call the ambulance, then you would do it by yourself. While waiting for the ambulance, do not leave the David alone. Do not leave David alone. Give him small sips of water. Give him paracetamol or ibuprofen. I will call you back in 10 to 15 minutes to check whether the ambulance has arrived or not. I won't be able to prescribe any, and the father or mother will say, and doctor, can you please prescribe for now? Then you will say, I won't be able to prescribe any antibiotics. He needs to take him to the hospital and assess immediately. Okay, the next scenario is eczema. Eczema in child. Eczema is a condition that is chronic inflammation of the skin, and it usually affects the flexor surfaces of the skin, and it is usually common in asthma in family history. It usually runs in family. Asthma and eczema usually runs in the family. FI2 and GP surgery. James is 15 years old boy. He has come to the GP with his mother Kate. He has got asthma. Talk to the mother and address her concern. So her mother is having asthma. Okay, so history of asthma and eczema in the family is important. Patient info: James was diagnosed with asthma. So the patient also has asthma. Uh, was diagnosed with asthma since he was 7 years old. Father and sister also have asthma. Jim is taking blue inhaler and asthma is well controlled. 2 weeks ago, he got rash behind his knees. Okay, behind his knees, it is a flexor surface. It is itchy and can be preventing. It is itchy and it has preventing him from sleeping at night. It has affected his school as well. Tried E45 cream which he bought from the pharmacy. This has not helped. Question: how will you help us? Is it because of his asthma? Okay, grapes confirm relationship topa of the rash. When did you notice it? Which part of the body do you have rash? Is it getting better? Anything that makes it worse? Is it itchy? Anybody in the family with the similar skin lesions? Okay, ask about the trigger factors. Do you have recently changed your soap? Because this is allergy. So in allergy scenario and derma scenario, you also have take care of the trigger factors. So have you recently changed your soap, used new soap, any new clothes, contact with the pollen, dust in the house, tried anything for the rash? So have you tried anything for the rash? He will say that, yes, doctor, I have used E45 cream. How frequently do you use the cream? How do you apply it? So in differential diagnosis, you will ask the symptoms of allergic reaction, eczema, and psoriasis. Psoriasis rash usually develop on the extensor surfaces, so it will develop on the knee and elbow. Ask about allergic reaction. Okay, ask about eczema. Usually it is on flexor surface. For psoriasis is on the extensor surface. Risk factors for eczema: any family history of eczema. Okay, any family history of eczema, personal history of eczema or asthma. Ask about PAM good, pneumonia, acute otitis media, meningitis, gastric symptoms, urinary symptoms, and upper respiratory tract symptoms and dehydration. Any red flags? Any red flags like bacterial infection signs and symptoms. PMA, Holy Family, OET examination, in fact, inspection of the affected area. So you will be given picture for that. Usually this is the case of derma, and it is also in PED scenario. So I have told you. Explain from what you have told me and examination finding. James has a skin condition called eczema, which is a chronic inflammation of the skin, which makes the skin dry and itchy. And usually affects the inner part of the knees, usually flexor part of the knees, and sometimes it is related to asthma. As you have already told me that you have used E45 cream and it has not helped, I will prescribe you another type of emollient called dermol. Okay, so there is a method to use this cream dermol. This should be used frequently and regularly. Number one, you can also use it as a shower cream or lotion. Should be used during and after washing. Available in all forms. Used daily. Should not be rubbed on the skin. It is not rubbed on the skin. It is usually applied in the direction of hair. You should avoid bubble bath soap. You should avoid the bubble bath and soap. You have to tell him that emollient should be applied on the wet surface after the shower, tap dry and then apply the emollient. So E45 cream has not worked, then you will prescribe another emollient, that is dermol. The dermol is usually not rubbed on the skin. It is usually applied in the direction of the hair, and it can be used during shower and after the shower. Dry the skin with the towel and apply the emollient in the direction of hairs. If it does not work in 1 to 2 weeks, then we will prescribe you some weak steroids. No follow-up is required for this buff. But if it does not respond, then you can make an appointment for follow-up. Safety netting is complications of bacterial infection, any pus oozing, any psychological problems, feeling low, then you can come back to us. Okay, the other scenario is also that of derma. It is urticaria. Urticaria is usually allergic reaction to anything, and it usually occurs on whole of the body. Okay, and it is like wheels. The rest is like wheels. Okay, one thing you have to take care in urticaria, that you should take care of anaphylaxis. You should look for the symptoms of anaphylaxis, and because that is an emergency. You should ask about the symptoms of breathing and difficulty in breathing, any swollen lips and swollen body. Okay. FY2 in GP surgery. Patient is 38. Daniel Pearson has some concerns about her 5 years old child Collie. Talk to the mother, father, and address her concern. Collie developed rash 2 days ago after taking a hot shower. So this is a trigger. Rash was all over the body. It was pink in color. Few hours ago today, she again developed rash while playing outside. So this is a trigger. So there are two triggers: hot shower and playing outside. Otherwise he is fit and well. No allergy history. Question: can it be contagious? Is it meningitis? Grifts, confirmed relationship. Topa of the rash. Where did it start first? Which part of the body has rash now? Has it spread to the other parts now? Is it the first time? How long has the rash last? How long does the rash last when it appears? Is it like wheals? So this is the proper characteristics of urticaria or allergic reaction, that it is like wheals, develops on the whole body and it appears for some time and it usually resolve on its own. So it is like wheals, rashes, itchy. Does she have any allergy? Is there anyone in the family with a similar rash? Is it painful? Differential diagnosis: allergic rash and history of sneezing, runny nose, possible allergen with new soap, new clothes, or any medication. Did the rash appear after eating food? Any pets at home? Was he playing outside in a garden? So this is a trigger. Was he playing in outside or in the garden? Anaphylaxis. So you have to take care of this. If you do not ask about anaphylaxis in urticaria, you are going to fail this scenario. So anaphylaxis history is important. Any difficulty in breathing, any noisy breathing, any swelling of the face or lips, meningitis, any fever, shying away from the light, any neck pain, bleeding disorder, anyone in the family history, insect bite, any chance she could have been bitten by the insect. Red flags are that of anaphylaxis, P mind, pregnancy, birth, immunization, nutrition and development, PMA, Holy Family, any past family history of asthma or eczema, and using any medication, any allergy to any medication, effects of symptom. Does it stop her from sleeping? Okay, does it stop her from going to the nursery? OET observation, examination, and test. I would like to examine the lesion. Do you have any picture of the lesion? That I have the picture with me. So you will look at the rash and the picture of your urticaria will be given to you. It is like wheals and it is very itchy. And from what you have told me in examination, she has urticaria, which is an allergic reaction. The rash is like wheals. It is more like that she has come in contact with something she is allergic to. Okay. Management reassured the father that it is self-limiting and will resolve on its own, because urticaria rash, it usually appears for some time, then it will resolve on its own. It will resolve on its own, but it is important to find out the cause of rash. For that, you can keep a diary of the rash in which you can note down the date she has rash, duration of rash, what was she doing, she had a rash, so what she was doing, duration of rash. All these are going to help us finding a type of allergen, whether it is itchy or painful or not. Any specific allergen is found. If any specific allergen is found, then we need to do a patch test to confirm. So in a patch test, a small amount of allergen is added to the skin like a patch, and then reaction is observed for 48 hours. For now, we can give you antihistamine to be taken as required. No follow-up is required. So the dad will ask you, is it contagious? No, it is not contagious, cannot pass to the other people. Is it meningitis? Highly unlikely to be meningitis. Meningitis usually present like a rash on the body's neck, stiffness, and shying away from the light. Next time she develops rash, bring her to the GP surgery so we can assess her rash and have a better understanding of it. Safety netting is that of meningitis, high grade fever, rash, neck, stiffness, meningitis. Enuresis in 4 years old child, FY2 and GP, Anna Green, 30 years, has presented with some concern. Other info, none. Talk to the mother and address her concern. Discuss the initial management. She has a 4-year son who is bedwetting only at night since birth. Child is toilet trained, goes to the nursery and happy to attend nursery daily. No evidence of stress or abuse at home or nursery. Normal P-bind, normal family history. What happened to my child? What has happened to my child? What will you do for my child? Will this condition be resolved? So approach, grips, confirm relationship. How can I help you? History of presenting complaint of Artopa. How long has he been wetting himself? Is it at night or during the day as well? Was he previously dry? Is the child toilet trained? Does he have easy access to toilet at night? Red flags. Red flags, P-bind pregnancy, birth immunization, nutrition, and development. PMA, Holy Family, any family history, any medications use, any allergy management. Explain from what you have told me, he has he has nocturnal enuresis like involuntary wetting during sleep. Usually tend to have child tend to have excessive urine production at night, and they have reduced bladder capacity. This is normal up to the age of 5. You do not need to worry about it. So this nocturnal enuresis up to the age of 5 is normal, no need to refer. So only thing you have to reassure the parents and give them some advices. So the decision, there are certain things that can help to reduce this. Avoid caffeine drinks before bedtime. Okay. Encourage the child go to the toilet before bed. If the child wakes up at night, encourage them to go to the toilet by themselves. You would use a reward technique. Offer rewards on the dry nights when the child goes to the toilet before bed. Okay. Offer rewards on dry nights when the child goes to the toilet before bed. Dry night. Make sure the child has easy access to the toilet, but do not punish the child because it is not his fault. Do not carry the child at night and force him to use the toilet. So whenever the child develop any urgency for urination, wake up the child and ask him to go to the toilet by himself, and also use the reward system. Give him some kind of chocolates for any good any dry night. Referral is only made in secondary enuresis if the child is dry for 6 months before, and that is very necessary to know if the child has been any dry spell before. So if secondary enuresis, the child remains dry for a period of time, then develop enuresis. So this needs to be referred to the pediatrics. So the last scenario for today is asthma. Okay, usually asthma comes with exacerbation of asthma in a child, and exacerbation can be due to 2 factors. One is the child is not using his medication, and others is infection and Infection can be viral infection or bacterial infection. So it is very important to rule out PAM good in asthma cases. So you also need to know about the spacers, because the child is not, if the child is not taking the medications well, not well, then he can develop exacerbation of asthma. So the right spacer and right inhaler use is very important. You need to know about spacer, the right color and technique, how to take care of it. And it is very important to take care of spacer as well. I have been asked to talk to you and find out what could be causing the recurrent asthma attack. So the steroid is preventer or brown inhaler. So the blue inhaler is salbutamol inhaler, and it is a reliever, and brown inhaler is steroid inhaler. During acute, is it cooperative with the medication killer of the spacer? So asthma in a child, telephonic conversation, FY2 and GP surgery, 6 years. Kelly has not been feeling well. His father has called the practice. He would like to talk to the doctor, talk to the father and address his concern. Patient info, opening sentence, doctor, my child is not feeling well. I think his asthma is acting up. He is running temperature. I have given him paracetamol, but the temperature is still high. He was diagnosed with asthma 4 years ago. He takes regular brown inhaler, that is steroid inhaler, blue inhaler whenever he needs it. He does not have any allergies. Question, what should I do? Can you prescribe him with some oral steroids? I can come and collect the steroid. Approach, telephone scenario is the same which I have already told you. Greet, may I know who is speaking? Introduce yourself, ask for details. How may I help you? Doctor, I feel my child asthma is playing up. Can you tell me more about it? Is the child breathing? Okay, these are red flags, so you have to ask them now. Is the child breathing? Is he sitting up? Is he drowsy? Okay, then TOPA of presenting complaint, that is shortness of breath or cough or wheezing. Differential diagnosis is PAM good. Ask about upper respiratory tract infection, pneumonia and asthma. Red flag sign. Ask about cyanosis or apnea spells, any retractions in the chest, any flaring of nose. These are the red flag symptoms. Ask about pre-bind pregnancy, birth, immunization, nutrition and development, past medical history, uh, what med diagnosed with asthma, what medicine, when was he diagnosed, does he take the inhaler, if does he use it regularly, and use it with the spacer. OT management. Explain from what you have told me, it looks like her asthma has gotten worse and she has viral infection. So it is infective exacerbation of asthma. The viral infection has made the asthma worse. Management, she needs to be taken to the hospital immediately, because it was a telephonic conversation. So the child needs to be taken to the hospital immediately. Do you have any means of transportation to go to the hospital? Usually no means. So offer call ambulance. I can call ambulance for you. While waiting for the ambulance, stay near Kelly. Remove all the objects around the child. Is she talking to you? No. You know, if she is talking, then it means airway is patent. Monitor the child. Keep giving salbutamol blue inhaler via spacer. I can call back in 10 to 15 minutes to make sure ambulance has arrived. Dad, can you prescribe steroids? She is in serious condition, needs to be taken to the hospital. There she will be assessed by the specialist. Steroid won't help him at the moment. Okay, the last scenario for today is also of asthma in a child. FY2 in pediatric department, the Adam presented with chest tightness and these other info. Respiratory rate is high, oxygen saturation is 94%. Talk to the mother and address the concerns. Patient info, for the last 3 days, Adam had fever, cough, sneezing. In the last 24 hours, he has developed wheeze and shortness of breath. He was diagnosed with asthma 2 years ago. Father has asthma history, mother has history of childhood asthma. Question, how is the child doing? Can we go home? Confirm relationship. Take the history of presenting complaint, that is chest tightness and wheeze. Ask about asthma symptoms like cough at night, chest tightness, wheeze and shortness of breath. Ask about precipitating factors like upper respiratory tract infection. So NSAID can also exacerbate asthma. Dust, anyone smoking at the home, pets, personal or family history of atopy or asthma. Okay. TOPA. TOPA is for chest tightness and wheeze, differential diagnosis in which you will ask about pneumonia, asthma, okay, and PAM good, ask about all the signs and symptoms of infection, red flag sign, P bind, PMA, Holy Family history is important. Her, her child was diagnosed with asthma 2 years ago. What medication does she take? Does she take any inhalers? How often does she have asthma attacks? Does she take steroids? Follow up with the specialist. What was done for acute episode of asthma? Salbutamol. How many puff? Did you use the spacer? Observation, examination, chest observation, chest examination, peak expiratory flow rate management. Explain from what you have told me plus examination. Adam has infective exacerbation of asthma due to upper respiratory tract infection or viral infection 3 days ago. Decision depends upon oxygen saturation. If oxygen saturation is less than 94, give oxygen, give salbutamol inhaler. Observe the child. If he shows response to inhaler, we will discharge the child home with oral prednisolone for 3 days. Follow up at GP in 2 days. If he does not respond, then we need to give nebulizer, observe the child, and we need to admit the child. Safety netting. If the symptoms get worse, then use salbutamol inhaler. If he does not respond, you need to seek immediate medical help, offer leaflets. So this is done for today. So the things which are important in PEDS is how you talk to the mother, how you show empathy, how you show e-protocol to the mother, how you answer the queries and concern of the mother. Okay, and it is very important. You should know the name of the child and also gender of the child. And also one thing is very important, that you should ask the symptoms which are important. That is PAM good, pneumonia, cough, fever, acute otitis media, cries while pulling the ears, any discharge from there, and also symptoms of meningitis, uh, any neck rigidity, any shying away from the light, any rash on the body, and symptoms of UTI, any foul smelling urine, does she cry while passing the pee, okay, and also upper respiratory tract infection like cough, sneezing, runny nose, and also gastric symptoms like diarrhea, vomiting, and also change in bowel habits. Also, dehydration is important in peds, and also pregnancy, birth history, immunization history, nutrition history. So these are the things of peds, and peds is likely similar to the medicine, just these are the difference. The one thing is very important in peds, you have to be very sensitive in peds, and you should talk to the mother or father in a sensitive way and listen to them carefully. And uh, when they have finished talking, then you need to talk to them in low tone and maintain the eye contact, and that's all. Do you have any questions? You can ask me now.